thank you everybody for joining. I am so excited that everybody has come along in order to be part of the second part in our series of Science of Engagement webinars. Now, some of you might have heard me say second part and thought that you didn't get to see the first part. Well, two things you should know about that. One, this is definitely a standalone presentation which works in isolation, but also that we will be sharing a link not only to this video once we've finished it today, but also to part one. So if you'd like to catch up on what you missed, then you'll have the opportunity to do so. Now, before I go on, I'd also like to make an offer to everybody, which is because we love talking about this stuff so much, we're actually going to be sharing a Calendly link at the end of the presentation, which you can click on, and then you can find an hour that suits you in order for us to get together, talk about any element of this presentation that you wanted to dive into in more depth, or indeed talk about some of the behaviour change that you might want to drive and how some of the models that we're going to share with you might help you to do that. Now, one more thing to mention before I get going, which is really we wanted to bring these frameworks and what I'm going to share with you to life. And so we decided to use a huge health communication problem in order to do so. And so what we'll be talking about today is menopause. And we'll be talking about how we can apply some of the frameworks that we have to the communication problem that exists within that particular area. So without further ado, I'm going to get started. Now, the first thing to say is I'm going to be sharing a lot of stats with you about menopause and about the impact of it, not just on women, but also on the economy. But before I do that, we must realize that this is a human problem. And in order to put that into context, I want to first turn to Laura. Now, Laura is a successful businesswoman who, as she started to go into menopause, started getting invisible symptoms like anxiety and loss of confidence. And you can see there that Laura actually even became a bit agoraphobic. And I think she puts it really well when she says, I felt as though I had lost myself somewhere, which really helps us to be focused in on the fact that this is a human problem that women are living through. Now, the other thing to mention at this point is that this did affect Laura's career. And the reason for that was that, in her own words, by the middle of the day, she felt so dreadful that she needed to go and take a rest in the afternoon, which of course wasn't conducive to working in her job and pursuing her career in the way that she had previously. Now, here are some of those stats I promised, and the first one's pretty obvious, that this affects 50% of the global population. But actually, in many ways, it affects all of us because, you know, if we have a mum or a sister or a female partner or a daughter, then of course we all love and care about women who at some point are going to go through this experience. Now, 77% of women experience very difficult symptoms through the menopause, and these can include things like brain fog, loss of sleep, and also anxiety and depression. 44% of women say their work has been affected, and to put this into context, 1 in 10 women in the survey that we looked at and are using as one of our sources of research said they'd taken at least a month off due to the symptoms of menopause. Now, of course, this is a human and a personal issue, but at the same time, it's also a societal issue because due to lack of productivity, the UK economy alone loses £10 billion a year. So if all of that is true, then why this dissonance between the serious impact that this has on half of the global population and only 14% of women in the UK are using HRT as a solution? And the reason for that is quite simply because of a miscommunication problem. And that came with the WHI survey and outcomes, which were wildly misinterpreted, linking much more closely than has turned out to be true breast cancer with the use of HRT. And so we have a real communication problem here, which needs to be addressed. Now, back to Laura. And Laura says women should do lots of research, and if your GP fobs you off, go and get a second opinion. Be your own advocate. Now, why does Laura feel that she needs to say that in her story? Well, the reason is that research shows that 39% of women who go to the GP or speak to their nurse practitioner about symptoms of menopause are actually not offered, only 39% are offered HRT, despite the fact that that option is available. And so when you consider all that, you know why Laura feels that women need to be their own advocate. So if we've got all this evidence of the impact and we have a solution and the two and one would solve the other, what's the problem? Well, at the very highest level, the problem is that we're talking to our brains and our way of thinking is not perfect. So our mammalian brain technology is 300 million years old, and actually it's responsible for keeping us alive. It's the part of us that wants us to survive, it wants us to reproduce, and it wants us to make sure that we have the resources necessary in order to do so. And of course, we got our upgrade about 3 million years ago with the neocortex, which allows us to do our analytical thinking. And that mammalian brain and the kind of instinctual responses that it drives are very important for the context of this presentation. But a bit more about the brain. The first thing is that we process 11 million pieces of information each second, and that's important because it shows us how busy our brains are, and that will lead to the point a little bit down the presentation. We process images 60,000 times faster than words, which is why a picture paints 1,000 words. And also, we need to think for a moment about multitasking, which is a thing we talk about a lot. Well, the truth is multitasking doesn't really exist. Multitasking is actually simply context switching. We can't think about two things at once. So, and when we do a lot of context switching, it can increase the error rate in the way that we make decisions by up to 50%. It's probably important to think about that in the context of ACPs, actually, because if you think about the context switching of seeing a different patient every 10 to 20 minutes, that's an awful lot of context switching. Now, the last part, and again, it's important, is that 20% of our energy is used on brain function, and we're not that efficient, which is why we've developed things like biases and heuristics to help us be more efficient, and that's going to come into play later in the narrative. Now, you might be familiar with Daniel Kahneman's System 1 and System 2 description of the brain, with System 1 being the part that manages instinct and emotion, and System 2 being the part that we really think about as the analytical part of our mind, the bit where we make more rational decisions. But actually, what I want to talk about is Johnathan Haidt's wonderful analogy of the elephant and the rider. Now, in this particular analogy, the elephant represents our System 1 brain. In other words, it represents the part of our brain that needs emotional motivation. And the analytical part of our brain is represented by the rider. And the rider is that part which makes all the decisions. Now, in order that we make the change that we want, we need to give knowledge to the rider. And so in this analogy, where they're going on a journey together, we need to give them the knowledge they need to get to the destination. So that's what we've got to provide to our rider. But the problem is we're dealing with a 6-ton elephant, and Johnathan Haidt is actually very careful to point out that this is a 6-ton elephant. And I think the reason he mentions that is because it's quite difficult to motivate a 6-ton elephant to do what you want unless you give it a really good reason. And so we really need to tap into the emotions in order to get our elephant, or the emotional part of our brain that helps us to make decisions as well, in order to get it to do what we want. But also we have to think about the path. And the path needs to be clear in order to allow for easy progress. And what we mean by this is that as well as having our brain, there are also external factors which need to be cleared out of the way in order to drive the behavior change that we desire. Now, I mentioned earlier the biases and heuristics which can affect the way that we think, and we're going to apply some of those to menopause and the communication problem that we have within it. Now, the first, the availability and recency heuristic, which we talked about in the last presentation, is really represented in this particular situation by the availability or the prevalence of negative information about HRT within the media, which is obviously highly available information. And so for healthcare professionals who were exposed to a lot of that information and therefore have it very available in their mind, that plays into the decision making which is going on despite some of the information which has become available since. The second is the anchoring bias, and this really talks to the fact that the first thing that we learn, or the first way that we learn to do something, or the first opinion that we form, we can often anchor to long term. So if we learn to do something as a child, and we get used to doing it every day, it's very difficult to learn to do it a different way. And this plays out again in our menopause situation, because and women can be anchored to that initial information that was received about the risks connected to HRT and breast cancer. And then finally, we need to think about loss aversion, because we have evolved in order to try and avoid loss more than we have evolved to try and make gain. And the reason for that is because we're ultimately trying to survive. In other words, we make risk assessments to keep ourselves safe over necessarily taking risks in order to make gains. So if we now know that we have a problem, a communication problem, where there is some dissonance between the information which is available about how women should be treated with HRT now versus the initial misinterpreted outcomes, we need to map out how to close the gap. In other words, how to move the needle on the behaviour change that we're seeking. So in this instance, we have to start with the business problem. And our business problem intrinsically linked to our business goal. So we want to achieve this, and in order to do that, we have to resolve X problem. So we think that through first, and then we can work that down to the marketing goal and the desired audience behaviour. So we're going to work out, okay, well, if this is my business problem, this is how I know I'm being successful by achieving that through my marketing, and I'll know that because the audience are behaving in a different way, and this is how I want them to behave. But we have to think creatively about what we want our audience to do. And what we mean by that is when we think about the behavioural problem that and the new behaviour that we're trying to drive, we need to ladder that back up to the business problem and make sure that it really is going to be the right solution. So it's basically retracing our steps, which is what we talk about here. So it's about checking our chain of logic. So we get down to our desired behaviour, then we think about making sure the marketing goal that we created really helps us to do that, and then we go back up to the business problem. And it's also worth assessing at that time whether we have tried to solve this business problem before, and think about, okay, well, if this is the business problem I've tried to solve before, and this is the desired behaviour I've tried to generate, but I wasn't successful, maybe I need to revisit my business problem. So really, it's just about retracing our steps, checking the logic that we've taken throughout the process in order to make sure that we're definitely on the right path. Now, let's go back to menopause and think about the business problem that we have. So HCPs don't understand the impact of menopause on women and have an overinflated sense of risks to prescribing HRT. So I think we've established that problem through some of the information that we've shared earlier. And we also know that our desired behaviour is to get GPs to listen to women. And I'm going to talk later about some of the reasons that we feel that maybe GPs aren't listening to women, and for them to understand the impact of menopause and prescribe HRT as part of a holistic treatment plan. So when we think about our behavioural problem, the current behaviour, in other words, that we're trying to change, we need to think big picture before defining our research questions. Now, what I mean by that is taking a look at the external factors which could be playing into the reasons that people are behaving the way that they are. And when I talk about big picture, I mean looking at things like, is there a narrative in the media which is affecting the way people behave at a really high level? Are there any societal norms or values that might be standing in the way of the behaviour that we're trying to drive? Or maybe creating shame, for example, or preventing people from acting in the way that we want them to. So we're talking big picture stuff. And if we then look at that big picture stuff and we've really examined some of the barriers that are in our way, we can start to do deeper insight into what lies beneath. So what are the emotional motivators which are therefore present and prevalent in the way that people are behaving as a result of those factors? And when we think about that insight, we need to think about both qualitative and quantitative data sources. So we might be looking at survey data, we might be looking at social listening, we might be looking at a whole array of different data sources, which really allow us to dive deeper into the real specifics around audience behaviour and the reasons they're doing what they're doing. And then we need to focus on what we don't know. And so another way of looking at that is we've done some really big picture thinking about the external factors that might be creating the behaviour. We've then delved into some of the deeper research into some of the nuances around the audience behaviour, and we've laid those out all in front of us in order to build an understanding. But then as we go through that and we review that information, we might start to see that there are areas where there are assumptions between links to things. And actually, it's those assumptions where we can go in and ask more questions to dive more deeply into some insight, which might validate our thinking, or it might actually change our thinking and the way that we're going to approach the particular behavioural problem that we're looking at, and ultimately how we define it. Now, what I'm going to do next is to introduce you to a model which was created by Susan Michie, working out of the University College London. And it's the COM-B framework, and it really breaks down into 4 particular areas. So the first one is capability. And capability really speaks to the factors around knowledge and about factors that might be standing in our way, like resources. So do the people that we're talking to have the skills and knowledge that they need in order to carry out the behaviour that we want? And are there external factors like time? So do they have the time to do the thing that we want them to do, or is that a barrier? And then we look at opportunity, and opportunity really talks again to those external factors. So are there social norms and values which stand in our way, or are there literally physical elements within the external environment that might be stopping people behaving in the way that we want them to? And finally, we have to go to motivation. We have to go back to our 6-ton elephant, and we have to think about whether there are automatic or reflective emotional drivers or barriers which need to be thought through in order to drive our desired behaviour change. And to sum up automatic and reflective, really automatic is around our system 1 brain and reflective is around our system 2 brain. So are there any emotional drivers and motivations that need to be considered through both of those lenses? Now, what you might have noticed is that there are some significant parallels here between Johnathan Haidt's rider and elephant and this COM-B framework, because ultimately we talked earlier about the capability being giving the knowledge to the rider that they need in order to get to the destination. And then the opportunity, as we said, is really the path, is the external factors that we need to make sure is smooth in order to allow for easy progress. And finally, we need to motivate the element. And so that means tapping into emotion to really drive the desired behavior that we're seeking. Now, back to the menopause problem. And what we're going to do now is go through the COM-B framework in a slightly different way, where what we've done first is we've applied the problems to the COM-B framework, and then we're going to flip to the solution and see how that aligns to the COM-B framework. So starting with capability, we know that HCPs and women lack understanding of menopause and HRT. And so we really need to ensure that we address that when we think about the reason that we see the current behaviour. The next is that the perception is that the menopause isn't a clinical priority. And the reason we say that is because we've looked at extensive research that actually shows there are quite a large number of healthcare professionals who don't view it as a clinical priority and feel that it's a natural part of a woman's life, rather than something that should be brought in and medicalised. And there's also a misunderstanding of the risks of menopause and HRT. And it's really important to talk at this point around, yes, the risks are really focused on. What we don't hear so much about is the fact that HRT can prevent osteoporosis, it can prevent potential links to cardiovascular disease, and also it can prevent cognitive decline and also dementia. So, we need to be thinking about those things in the balance of HRT versus some of the misrepresented data that I shared earlier. The next thing is around the opportunity. So GPs lack up-to-date information out in the universe, and we need to find a way to resolve that. And then there are negative societal attitudes towards menopause, and we did see a lot of qual and quant data which supports this in the research that we did. But the bit that really jumped out at me was actually the personal stories of a number of women where they were describing interactions within their home, where family members were describing them as mentally ill as a result of some of the symptoms that they were exhibiting as part of menopause, which feels very uncomfortable. And it really links to the next point, which is around negative portrayals in the media. And we've seen these negative portrayals and the impact that they've had, which I described earlier in terms of the framing of the WHI outcomes. Now, looking at motivations, GPs are afraid of getting it wrong, and maybe we would say so they should be. Of course, healthcare professionals want to do the right job, of course, but there is a fear of around the risks which outweighs necessarily the gains which can be created through prescribing HRT. And GPs find menopause awkward to discuss. We actually saw that lots of male healthcare professionals reported feeling awkward about talking about some of the more sensitive areas of menopause and the symptoms that manifest. And they're also worried about medicalising it, as I mentioned earlier. And we also know, and it's probably no surprise by the time we've gone through the rest of it, that patients feel shame, embarrassment and stigma around talking to healthcare professionals and in general about menopause symptoms. And so I think the phrase is probably suffering in silence. There is way too much suffering in silence. So enough of the problems, let's move on to the solutions. So around capability, HCPs need time-efficient and easily absorbable and pertinent solutions so that we can provide information which is going to lead to the desired behaviour by re-education. We need to make HCPs and women feel that menopause symptoms are a priority. And as I said, there are actually lots of instances, around 39% of women are offered HRT as a first-line treatment when they go in and talk about menopause symptoms, but that's way too low, and that's because menopause symptoms aren't necessarily seen as a priority. And we need to help both women and HCPs understand the potential of HRT. So we need to move away from the risks, although, always in balance, but we also need to talk about the potential and how it can be life-changing. Next, we look at the opportunity and supporting HCPs with up-to-date information, diagnostic tools and guidelines. So we need to look at the external universe and the places where HCPs gather and use information. And we need to make sure that the information that they need and the tools that they need are prevalent and available in those spaces. And then we need to tackle negative societal attitudes that surround the menopause and indeed HRT, which intrinsically links, of course, to helping media drive the right messages so that we can positively engage both women and HCPs in the solution and towards the desired behaviour. And then finally, there's the motivation. So how do we motivate HCPs? By framing the risks of not prescribing HRT, as opposed to framing the risks of prescribing it. We also need to think about normalising and destigmatising menopause for both HCPs and women. So in other words, we need to address the embarrassment and the awkwardness that I was talking about earlier. And all of that adds up to removing shame and empowering women to advocate for themselves, if we take it back to Laura just for a moment. Now, having done that and having looked at everything that we've learned through our COM-B framework, we can then get started on planning our intervention. And ultimately what this means to begin with is creating our communication goals. And so I'm sure many of you will be familiar with this framework, but first we're going to look at healthcare professionals and we're going to think about what we want them to think, do and feel. And so firstly, what we want them to think is that it's important to treat the menopause and also that there are safe treatment options available. What do we want them to do? Well, we want them to hear women, we want them to listen, and we want them to offer a supportive experience and ultimately a holistic treatment plan, but that should consider HRT as a first-line treatment for suitable patients. And what do we want them to feel? Well, we hope that they would feel empowered and hopeful, because by doing all of these things, they can make a real positive impact on the lives of women and, of course, their families as well. Now, looking at this through the lens of the patient, we want them to think about the vast range of symptoms and understand what those are, because often there are situations where, actually I'm going to tell you this story. It's just popped into my head. I was talking to a good friend of mine who's in her mid-40s yesterday, or maybe late 40s yesterday, about the fact that I was going to deliver this presentation. And she said to me that she was driving around the local town here, and she suddenly found herself literally not knowing where she was going, or what she was doing. And this happened over and over again. And she didn't understand at that initial point that it was a symptom of menopause. And she actually thought that she might be going into the early stages of dementia. And so that personal story really brings sharply into focus the fact that women do need to understand the vast range of symptoms that may be associated with that period of life, and also that there are safe treatment options available. What do we want them to do? Well, we want them to visit the GP and ask for information, support and treatment options that they deserve. And we want them to feel heard, and we want them to feel supported, and we want them to feel that what their experience is a clinical priority and that their doctor is the person who's going to support them through it. Now, what we've done in this presentation is we've taken you down from the business problem right down to the communication goals. And in the next part of our series, we're going to go from those communication goals into campaign planning, so we can start to see how this comes to life in a series of experiences that help to create our intervention and drive the behaviour that we want to. But I hope it's been really useful in taking you from the business problem down to the communication goals, and that some of those models resonate with some problems that you might apply to the same framework. Before we go, let's have a look at a few key takeaways. Number one, don't forget the 6-ton elephant. We must remember that sometimes we're really good actually at seeing information gaps and then filling them in the way that we communicate with audiences. So we see a need for, we might see that through all sorts of data sources, that this information isn't available. So we present information. But unless we've really motivated the 6-ton elephant and provided some emotional motivation to drive change, it's not going to have the effect that it should. Second is that we really need to understand our problem in order to do the right research. That research is critical to really make sure we end up with some unbiased insight that really drives our decisions about the desired how we're going to get people to behave in the way that they want, by really understanding why they behave the way they do now. The next one is, please consider all COM-B factors to drive change. As you heard, we need to make sure the rider has all the knowledge they need, we need to clear the path, and we need to motivate the elephant. So it's making sure that we think about all of those things as we plan our intervention. And finally, we talked about laddering back up earlier, but it's time to ladder back up again with respect to getting to our communication goals, and then going all the way back up the ladder to our business goals, including our business problem, our marketing goals, and desired behaviour, to make sure that the thread runs smooth throughout them and that we haven't lost our way anywhere. Now, what I'm going to do now is I'm clumsily going to attempt to use the COM-B framework in order to talk about the thing that I'm hoping that you're going to do. So we talked earlier about our clinics, which we're setting up because we really do love talking about this stuff and sharing this thought leadership content, and also looking at and tackling problems with people that they might be having that we can help with. So please do sign up to our 1-hour clinics, which we will be providing the Calendly link for. Now, hopefully we've given you the capability to do so by giving you the information you need to know that they are available, and providing some of the information about what might be discussed by holding this webinar. The second part is, I hope we've given you the opportunity by clearing the path and making it really easy, giving you a Calendly link to use in order to make it really simple for you to make that time with us. And thirdly, I hope that we've delivered the motivation by really allowing and building an understanding of the fact that really, if we want to drive change, then we do have to consider how to incorporate behavioural science and the science of engagement in the way that we approach our audiences. And with that, I will say thank you so much for your engagement. Thank you for being part of it, and we'll see you next time.